Decolonizing Global Health and what that work is actually in practice. So from country initiatives and educational institutions and implementing agencies. Our co-hosts for this event are Medicus Mundi Switzerland and Medicus Mundi International. We invite the audience to participate with vigor in the Q&A session later in the event. You can type throughout the event any questions or comments in the chat box. And if you want to address a question to an individual speaker, you can do that as well. Our moderator today is David McCoy, the Evidence to Policy Research Lead at the United Nations University International Institute for Global Health in Malaysia. So David, you have the floor.
Many thanks, Ellen. And I hope my audio is coming through to all of you from different parts of the world. Welcome to this panel discussion. Before we start, I'd just like to acknowledge the fact that there are all kinds of terrible things happening in different parts of the world. There is violence and there is a great deal of human suffering, some of which is directly related to the topic that we're going to be speaking about today, colonialism. So it's just something to acknowledge as we proceed with our discussion tonight. We have four fantastic speakers to kickstart the conversation. They are Ravi Ram from the Kampala Initiative, Hafid Debal from Terre des Hommes, Schweiz, Danny Gotto from Innovations for Development in Uganda, and Agnes Binakwaho, retired Vice Chancellor of the University of Global Health Equity in Rwanda and former Minister of Health. Please, can I encourage all of you to read their full bios on the event webpage to get to know them a bit better. And before I continue, let me really just kind of extend my great pleasure and gratitude for being invited to moderate this conversation. We're going to start off with Ravi Ram providing some initial remarks, providing some context about the topic of decolonizing global health from theory to practice, after which we will have a discussion with the three other panelists. And then there will be time for questions from the audience. So I'd just like to encourage you to stay to the end and think about questions that you might want to pose to the panelists. So before any further delay, let me welcome Ravi to give his initial opening remarks. Over to you, Ravi.
Thank you very much, David. I'd like to just start off with a thanks to the Graduate Institute, Ellen and her team, as well as Martin and his network of Medicus Mundi Swiss and International. So I'll just do a very light touch overview or introduction to the ideas behind decolonizing global health, looking at moving from discourse to practice or analysis to action, and touch on a few areas where civil society is moving ahead, and perhaps also looking at some of the structural changes that we want to see. So first, just a few notes about decolonizing global health. There has been substantial analysis, and that's been very productive, but we've not seen enough action that builds on this analysis. So that's where a lot of us are coming together in a variety of networks and in today's webinar. Let's see what we can talk about. First, let's think about decolonizing global health. Some people ask, what does that look like? What does it mean? And I've put a few ideas from my own understanding and experience. Number one, it's much more process oriented. It's not that there is a clear goal that we're moving toward. We know what kind of changes we want to see, and we will work on those, and we'll trust ourselves, our brothers and sisters, and future generations to build on our own actions. But the guiding lights are that we do need to see a change in the power structures and the way that different actors in global health work. I'm put over here that it's not just limited to the global south, global north, and that is a key structural impediment to decolonizing global health, but also within countries, because we're increasingly seeing that it's not just an international issue, it's also global health has its roots also in how structures are based nationally. That's where I'm emphasizing we do need to look at national health structures, regional health structures, and how those relate to global interactions. Now, having said that it's process-oriented, I'd also like to say that we are evolving toward people-centric health systems, global health architecture, and ways of financing or moving not just money, but other resources across countries and even within countries. And when I say other resources, I'm primarily thinking of people, whether it's health workers who are moving across boundaries because they're seeking better opportunities economically and otherwise, but also people who are seeking better health care. And we need to see what are we going to do with our health systems so that people are, wherever they live, they're able to find the kind of health system and health services that meet their needs. So putting together just a few notes over here, and I'll share links in the chat. Looking at the action point of view, not going further in analysis, but the actions. I've put forward this idea of the global code of conduct or global code of practice on recruitment of health personnel. It's a non-binding code that WHO put out back in 2010. It helps set up some norms. It's non-binding, so it's in maybe an operational sense, it's been ineffective. But it has raised the standard and raised the discourse to, okay, we know this is a problem, we actually have to do something, and this is a step. It was much overdue at the time, and the tragedy is that there hasn't been further steps since then. That's my own reading on it. But I'm putting it forward as something that we can look to in terms of decolonizing global health. This is a structural change in how we're managing health workers or intending to manage. Then I've also put here the global public investment, and then GTI has its own network. And here that's looking at how are we going to not just look at donors and recipient countries, but say on a solidarity-based model, what are we going to do that we can actually say, I don't like the term investment, but that's what they've used. We're going to pool resources together toward a common goal. So that this is something that's working toward, and they have their own network that's working toward that kind of concept. Now, I'm also looking at several progressive non-governmental organizations, and I've highlighted 3 over here right now. I guess a full disclosure, I'm actually a trustee with Health Poverty Action, but I believe all 3 of these organizations have made some steps in their own implementation and their own values that we are going to decolonize our own work. It's worth noting that all 3 of these are northern-based international organizations. And despite that, or maybe in part because of it, they recognize that they have a role in the coloniality of existing global health interventions and structures. So Stop AIDS came up with an anti-oppression framework that they're now applying to their programs, both in the UK as well as globally. Harm Reduction International, I believe that Naomi or Colleen is on this call, and I'll let them speak for themselves about what they're doing, either in the Q&A, the discussion, or in the chat. Health Poverty Action is right now convening its own staff, its management, and its trustees to look at what its role in coloniality is and how they can move toward decolonizing their own work. And then I've also put here the Kampala Initiative, of which I am also a part. Set up in 2019, the Kampala Initiative has been promoting these kind of examples of where civil society can not just further interrogate decolonizing global health, but also give voice to those who are taking action. And I'll add the links over here. Danny, who's also in our panel, will talk a little bit more about his own work through the Kampala Initiative. And then we've talked about neocolonialism and how decolonization in a political sense happened, or in a sovereign country sense happened from the 1940s to the 1970s. But there is expressions of colonialization in other interactions. And I'm looking at specifically South-South, because from where I see things, we need to be not just looking at a global South versus global North. We need to be looking at what's happening with powerful actors wherever they are. There's been a lot said about the China Bridges and Roads Initiative. I think that's something that we need to explore further, because there has been a lot of discussion there, and we need to see China as an actor in global health and not just global trade. of the Asian Infrastructure Investment Bank. I think in many ways it's also not Western-led, but nevertheless following the same models as the IMF, the World Bank, and other actors. And I think this deserves further action by civil society to make sure that its trajectory, it's only been around for, I think, 6 to 7 years, does not follow and reinforce colonial structures. Then I put in here other states. India has also been following in many ways a colonial mentality toward its development programs. And we saw that even in COVID, where protectionism overruled their own public commitment toward sharing vaccines. Brazil is doing the same kind of work in Latin America, again, using its regional dominance in trade and other economic factors to dominate smaller states. And then even within Brazil, much of the indigenous population and also the Afro-Brazilian population has been excluded from the formal health system. I put Mexico here because I've had interaction with Amexid, the development arm for the national government, and they have taken in some ways a progressive approach toward working with sister states in Central America and even the Andes cone. So I think it's worth watching what Mexico is doing and seeing if they're continuing to follow that or not. One other point I'll make, just outside of the Southern institutions, the government of Netherlands had for some time supported Southern-led advocacy programs in health. It was a refreshing approach. They had not continued it, but there are some avenues to explore in terms of those that are willing states. And I think it's worth discussing that further here, especially because they put real money behind it. Southern institutions, and I can say that there are some institutions, even here in Nairobi, that have surrendered their perspective as a Southern institution in order to get additional, not just funding, but I've also put over here incentives, access to global institutions, a seat at the table, but not necessarily representing their own ideals in community health or in alternatives to a neoliberal ideology. They've in many ways sacrificed that in order to enhance their global stature and also their funding base. So that's examples of both positive, neutral, or areas to watch, and then also some negative aspects where we can no longer just say it's the South versus the North or North versus the South. There's actually decolonialization needs to happen within the South as well. But now looking ahead, some opportunities. I'm putting the WHO Civil Society Commission up here. It's very young. It's only 2 months old as of now. And I'll confess, I have a role over here. I want to see that this commission can help bring voices to decolonize global health. And that has to be done in a very structured manner. WHO is actually giving a lot of attention to this new commission. At the same time, we know that there's risks with any kind of civil society, whether it's an engagement mechanism or other kind of seats at the table. There's a risk that it becomes tokenized. We've heard from civil society, we can move on, ignoring the huge diversity that's really the strength of civil society, not just a few voices at the table, or that it can be marginalized. Let them talk by themselves and we'll continue to do our own work. So there's some real concerns about what's going to happen with this commission. I mention it because it remains an opportunity to bring the voice of decolonization to WHO, the Secretariat and the member states. There may be potential to bring things to the executive board meetings in the future, as well as the World Health Assembly. So this is an area to watch. The Africa CDC, because where we are in Africa, our national health organizations don't have the capacities or strength with human resources and direct funding to represent a lot of what's going on. But the African Union coming together and putting forward the Africa Center for Disease Control and Prevention represents a potential for actually articulating African voice on health equity. And I'll be keen to hear from Agnes as well on this. And then lastly, some of the northern donors are talking about localization and equitable partnerships. I see equitable partnerships as potential. I've seen there's some real good actions in terms of making sure that if we're doing research, we're making sure that Southern leaders have extra attention because where we are in the South, we have incredible talent at the doctoral level and incredible researchers, but the mid-level is just not enough. And so we'll often have professors who are also putting together participant lists, and it's consuming too much time from them. So the kind of overall infrastructure to help the South be able to articulate its voice is important. And I put localization here because, as I talked about with some Southern institutions, it's necessary but not enough. And it can actually, if the focus is localization, that's important, but it can actually lead to negative consequences. It needs to be packaged along with other actions. So wrapping up very quickly, I will put a lot of the links to the organizations that I've mentioned into the chat as we proceed. I very much want to thank you. And I'll hand back to David now so we can hear from the panelists.
Great. Thanks so much, Ravi, for laying out some initial remarks and thoughts. Now, we're supposed to kick off the conversation with Danny. I see he's just appeared on my screen. So he is with us. Welcome, Danny. Nice to see you again. Danny, your work on urban health equity in informal settlements in Kampala uses what you call participatory urbanism. Can you briefly explain to us what this means and how this fits in with the decolonizing discourse that Ravi has initiated the conversation on?
David, good to see you. Thank you for having me. I struggled connecting, living on this part of the world where there are technical glitches, but I'm glad to be here. Yeah, so participatory urbanism in our context, I need to give you a little bit of a background. Most urban spaces, urban areas in Africa came from colonial history. So the colonizer really organized spaces and prioritized where they would stay, where those workers would stay, and where the rest of the communities would stay. So ideally, the poor, not well off within the social hierarchy, were relegated to what they call informal settlements. Now, the word informal means you are not recognized. Policy doesn't see you, investment doesn't see you, support doesn't see you. So there you are there. Politics doesn't listen to you. So participatory urbanism is a concept that we came up to bring the voice of the marginalized, the so-called informal, in part of the mainstream public policy. And the way we did it was to identify, because ideally most people think that if I'm living in the informal setting, I have nothing valuable to add to policy. I have nothing to add to development or to the practice of it. So we created a space for people in informal settlements, so-called slums, to come up and voice their concerns based on their context, based on their cultures, based on their interests, based on their aspirations of the people. And then we created a space for dialogue between policymakers and the common person to ensure that they decolonize urbanism, because the context of urbanism as borrowed from the West is that the poor live on the fringes, the well-off live in where infrastructure is good, healthcare is good, schools are good, and nobody cares. And often when developments would expand, they would be affected with displacements. So our position is that the poor, or those who have less, must participate in development, must be centered in policy, and their voices must be heard within those that are taking decisions on their behalf. Because also they're contributing, they're educating their children, they're feeding their babies. So that is what is participatory urbanism. Thank you, David.
Fantastic. Thank you, Danny. And everything you described makes me think about the Alma Ata Declaration, which, put at the heart of that concept of primary healthcare, the notion of community involvement, community participation, community empowerment as a key component of health improvement and health systems development. Danny, thank you. Let's move on to Hafid. Hafid, you work on sexual and reproductive health and rights for an organization that's actually based in Switzerland, but it's working in a number of countries in the global south. Now, can you tell us what kinds of structural changes your organization has made in order to decolonize itself, and what have been the challenges in that process?
First, I'll mute myself. Thank you again for the presentations. Thank you, Ellen and the team for the invitation. I think background and the position from where I'm speaking from matters here. So quickly to say, I work for an organization that has a budget of around $10 million annually in implementing in different parts of the world. And I'm one employee of this organization. I have no decision-making position, but I have a word to say and what can be my role. And I think in this discussion, because I saw there are so many people that are interested in this topic, many participants, I guess most of us are practitioners in kind of my position in a big organization or small organization. And the basic question is, how can we be drivers of these discussions that are not new, but happen again and again and again at different times with different dynamics. What is important here is in our organization, we had this discussion of, okay, how can we decolonize our work? And to be aware that in the networks we work within the organizations, the different departments, we have different backgrounds. We have different knowledge about post-colonial studies or colonial past, context, etc. And to be able to get everyone in the boat to take institutional decisions on changing processes takes time, but you need to create those platforms of discussion. And one of the key moments for us a couple of years ago, it happened at different levels, was to say, okay, our work has evolved over the last 50 years or 60 years. It's not as what we did in the 60s, not like we did in the 80s, 90s. So where do we want to be in 10, 15 years from now as an organization? What does it mean? And to have that reflection on decolonizing our work was mainly, and I think I'm pretty thankful for Ravi's input, where it becomes practical is how can we shift power? So where do I have power in my position as an employee? What kind of power decision-making processes do we have within our organization? And how can we make a shift towards a more inclusive and really equitable and equal system? And I'll mention a couple of points, and I'm afraid I can't go into detail for lack of time, but one basic point was for the strategy 2030, create different working groups on finances and fundraising, on trainings, on how do we want to deal with climate change, and so on. And these working groups are not based as we have now a headquarter. It was about to think, so who is part of these working groups? Who's leading them? And is the outcome open? And it is. So we have a group working on shifting power, like with all the employees. And then this is still within Interdisciplinary Schweiz. And this is, I think, what Ravi was referring to with localization. Have that discussion about, are we speaking about localization, shifting power, decolonizing? And who is ultimately benefiting from our work and these changes? It must be the people we work with, the local organizations, the civil society. And we created structures to include that voice in these processes, kind of an international youth network, because we work mainly with youth. We have a community of practice with our partners. Key to say that we don't implement ourselves, but we implement with local partners. And as one example, as in working group finances, it's important to have that discussion of to say, we do not do fundraising in those countries. We do it here. But in the countries, it's key we support our partners, local partners, into doing fundraising. And having that discussion, those spaces here were key in contributing to decolonizing our work. And we really need to be careful about what decolonizing means and mindsets and structures, and where we can actually structurally change things, like in shifting powers, practically doing. I could go on, but I'll stop here to hear also my colleagues, and I'm happy to get back to questions. Thank you.
Great, thanks, Safid. A lot of food for thought there. Yeah, and certainly the way in which international NGOs work with their counterparts in the Global South is a really important part of the ongoing conversation. But before we discuss that any further, I'd like to bring in Agnes now. Agnes, I'd like you to really say a few words about the University of Global Health Equity in Rwanda, which to my mind has attempted to produce a form of public health education that is very different from the traditional and, I suppose, largely colonial influence programs of public health that have been inherited either from Europe or from the US. Can you say a little bit more about how decoloniality informed the teaching and education of that university in Rwanda?
Do you hear me?
Yes, we do.
Yes. Hello, everybody. Thank you for having invite me to this very important subject. And that's true that we need to put definition around the words because it's a little bit of everything and sometimes nothing. So your question is very important. And at the University of Global Health, we are at the front of transformative education. So many things start through the way we educate our youth. And it emphasizes a decolonialized approach to public health and health service delivery. First, we educate students to amplify the voice of the marginalized and vulnerable people in the country, the region, the societies, the communities, and families. We teach them also that they are very lucky young people and less young because they had the chance to reach such level of education as we are. And we teach them cultural humility. This is at the heart of our education. And to provide such education, we have built the university in a remote area of the poorest district of the country at that time. And we educate our students inside the communities, the most in need in the country, so that once trained, we have students from all over Africa and some from other continents. So once trained, they are comfortable to work in similar environment to serve and build the health sector for the underserved in their country. Normally, medical schools are often in cities and in the richest part of countries, not where the most needs are of health professionals. On top of that, we put our students in direct contact with local, national, and regional leaders. We take profit of our connection inside Rwanda with the Ministry of Health, but also inside the continent with African Union and other official organization to train them to address the leaders that have the political power and decision. We also collaborate closely with the Ministry of Education, of Agriculture, of Labor inside the country and all the important sectors that are important for health. We use global as well as local best practice to teach our students to do so when back home because they are educated on analyzing and shaping health policies and improve the educational system in their country. So they will improve the work, but also the education that will produce their future colleague with capacity to transfer theory, but also capacity. So this approach has been pivotal in refining healthcare quality, improving access to health services, and create an efficient local, national, and regional partnership capacity and potentiality with real support to the community. Don't go and give a hand to your major partner outside the country without including the community and assure that there is community engagement. So UGHG commitment to diversity is strategic. In our class, we have students from all over the world, and they are returning in their native country to apply their knowledge in the most underserved area, decentralizing expertise and benefiting local communities. At UGG, these students are encouraged to share their culture, to be confronted to other way of thinking. This education use practical tools to address health disparities, provoke actionable change, empower dynamic in families, communities, countries, and regions. In a remote area of Africa, we are setting new benchmark for global health education. It is part of a global health decolonization plan.
Right. Fantastic, Agnes. I mean, that sounds so inspiring, and it's great to see this kind of curriculum being developed by Africans for Africans in a way that doesn't simply mimic the kind of teaching and curriculum and education that has been exported to many parts of the global South.
And if you see, our mission is by African for the world. Not
For the
only
world,
for
even
Africa.
better.
If the world doesn't change, Africa will be in bad shape.
Absolutely. Thank you. So, yeah, I'm just going to try and summarize a little bit of some of the key themes that have come out from that initial round of comments. So, I mean, clearly the theme of empowerment comes out really strongly. We see this in what Danny has described, but also, Hafid, you've talked about the empowerment of the partners and the people that you're working with. So, all of this speaks really to a bottom-up approach to health improvement, and that bottom-up approach, I guess, is very much, in my mind, a decolonial approach to global health that speaks against, I think, the prevalent top-down approach that we've seen over the last 2 decades in particular. The continuation of top-down, vertical, selective primary healthcare programs, often centered around a select few commodities and technologies. That approach has been called selective and vertical and top-down and donor-led, but in some ways it could also be described as a colonial approach to health improvement. And what you've described is a decolonial bottom-up approach that seeks to empower those that are currently least empowered. I also was struck by what you said, Ravi, about reminding us about the code of practice around international recruitment of health professionals and how the brain drain can and should be seen as a form of colonial plunder. It's not necessarily that we should be simply talking about, the plunder of natural resources, but also the plunder of human resources. The brain drain really is a form of perverse subsidy from poor countries to rich countries. And that is something that should be seen in the framing of kind of contemporary colonialism. One of the things I thought was missing, however, was the kind of role of the corporate and financial sector in today's globalized political economy. What we see in so many economic sectors, whether it's agriculture or in energy, or indeed the information communications technology sector, we see a growing monopolization of entire economic sectors. And with that monopolization, we see all forms of profiteering. And with that profiteering, we see, the kind of current obscene levels of wealth concentration where 10 men, according to Oxfam, own as much wealth as the bottom half of the rest of the world's population. So I'd like to just throw that out to all of you as a comment, really, or see if you can reflect on that point about whether we should be thinking about a corporate and financial colonialism that is occurring today. And just to kind of, bear that in mind when we go through with the second round of questions. And on that second round of questions, let's begin, I think, with you, Ravi. Perhaps let me put that question of financial and corporate colonialism to you and ask you to reflect on that in relation to what you presented earlier.
All right, thank you, David. Very good points about the commercial determinants of health in many ways and corporate colonialism. Just a few points, and I'll give an example also. Number one, we've seen that member states in international organizations, they won't necessarily be representing a national interest in the sense of the public. They'll be representing a corporate interest. And we've seen that, most glaringly during the COVID-19 emergency phase of the pandemic. And as much as public investments had been made in the rapid production of vaccines, which were not the only solution, but nevertheless, those vaccines were then restricted to national populations, and sharing the recipe of the products of a public investment was barred. So therefore, manufacturers in South Africa, for instance, were unable to produce this vaccine because they would have violated WHO regulations despite the TRIPS waiver. And then we spent years going through how can we put in place the proper waiver and got nowhere. And it's only because the power dynamics, countries in the global south that stood to serve their populations, as well as in a few cases profit from local manufacturing, were unable to move northern countries that had provided public resources for the production of vaccine, and then restricted it to their own manufacturers and ultimately their own populations. So that's one example. Another one I'll say actually, and you talked about corporate involvement and how there's monopolization of certain sectors. I would, I'd also call attention to what's happening here in Kenya, where a lot of health service delivery is being increasingly encroached upon by Indian corporates, where the Indian private sector is probably one of the most privatized in the global south, certainly in terms of scale. And they're looking at Africa as another ripe market. And so as much as there's been medical tourism of wealthy Kenyans or even Ugandans traveling to India for care, now that I think was a signal to Indian corporates that there's a market here. And they've set up private clinics on initially a franchise and now a network model to tap into the African market. And as we've seen at any kind of private sector involvement in health, the market fails. And it fails on many levels, whether it's pricing, whether it's service delivery, whether it's equity. And moreover, it increases the amount of resources available for state capture.
Yeah.
So similar kind of things are happening with South African insurance companies entering the Kenyan market. So these are, again, examples to be looked at very carefully. I'll hand back to you.
Great. Thanks, Ravi. Danny, just kind of building on this point about, the contemporary forms of colonialism and how we're seeing such increased concentrations of wealth with continued impoverishment, and how, the geographic pattern of wealth and poverty has been changing as a result. So we have now millionaires and even billionaires emerging in the global south. We also have growing impoverishment in parts of Europe and North America. We're seeing this shifting geography in terms of power and wealth distribution. And that kind of brings me to the question, a bit like what you're saying. You're talking about informal settlements, or populations living in informal areas within the global south as a distinct population group within that country or within that region. So how do we kind of talk about this? How do we talk about these different population groups? Because it seems to me that the global south, global north distinction is losing its purchase, because we're getting much more complicated transnational structures of wealth and poverty. What do you think about that? How do we what language do we use to describe and discuss these asymmetries in wealth and power?
Yeah, I think language is really an interesting concept because it can dehumanize it can devalue, it can delegitimize, it can stigmatize, it can make people invisible. So I think the colonial setting, when you look at history, how was Africa looked at? When you go back in times, it was a dark continent. Now, the implication of the dark continent means that those who were there were not human, maybe less of human. Progressively, when you look, Africa has always been looked at as a destination that has been shaded with poverty. Now, when you even look at investment and how much comes to Africa, maybe interesting in private sector investing in Africa, it's very low. Ravi was talking about the burden. When you look at the burden of disease, Africa's burden of disease is about 27% of the entire global burden of disease. Our pharmaceutical capacity of what we produce for our disease is less than maybe 3%. But we're a market for somebody. There are people who are literally refusing to invest in Africa because they have taken the narrative that Africa is a diseased continent. It is people who, when you Google any media, international media about Africa, you'll see starving children, you'll see shanty spaces and stuff like that. So that in a way has, made a narrative that influences how capital flows, who gets access to what, and what appetite in terms of interest comes through. I think as Africans, we need to tell our stories. We need to create our own channels that communicate who we are, what our aspirations are, and what successes that we are doing to push back the narrative. And when I'm getting in communities in Uganda here, and even in those spaces which are quote unquote informal, poor, people are doing amazing work. But of course, they do not have the narrative, they do not have the space where they can highlight that amidst the chaos, something good is happening. And I am very positive with the young people now when I look at them and how much they're taking agency and effort to improve their lives. And that pushback is what is going to revolutionize the discourse and then give people the power they deserve to occupy the space because it's their inherent right to be.
Great. Thank you. Thanks, Danny. Hafid, I don't know if you want to comment also on that same
on the two issues. I think yes. Thank you for sharing these thoughts. Maybe on the first one, when we spoke of, so what can be our role? Again, I mean, for me, it's always the question: what can I do practically? So the context we all agree on, but okay, what is then the strategy we can adopt individually or in our institution? So one of the working groups we had is on advocacy. What kind of advocacy do we need in the future? And one of the and what would be our role seated here in Basel? So I don't need to go down to South Africa and tell a 55-year-old woman who's been fighting for women's rights her whole life to tell her anything about gender transformative work. But these are the structures we have. Having experts in headquarters going down and telling people things. I think this is the first issue: is what is our role now, and what should be our role, and how can we make it happen? I think one of the roles we have is to sensitize donors, societies, etc., on these points. So when we spoke of advocacy in the South, one of the strategies is fund more South-driven advocacy, as Ravi mentioned. But what kind of advocacy is needed here? It's advocacy sensitizing for the kind of funding mechanisms that we still have here. So we have a funding mechanism for aid, and then at the same time we fund corporates who are really in counterpoint to all our efforts. So this is one issue on how we can work on advocacy. And then you mentioned with David the language, and David was mentioning also images. It's not just a matter of the words that we need. Words matter. Language transports power and power dynamics. It's, for example, we don't empower youth. We want empowered youth. We don't what we seek is not passive actors, is really active citizens and actors of change. And to frame it like that is a totally different dynamic. I remember 10 years ago, and I'll stop on this. 10 years ago, I brought back a picture from a mission where a young, very advocative man was holding, in a rural community in Zimbabwe, was holding a cell phone in his hand. And he wanted to put it away. And I said, no, keep it visible, please. I took that picture, I came back, and our fundraising department, that's really 10 years ago when we're not there anymore, did say that they could not use that picture in the global public because that gives a wrong image of needs and necessity. And these are the discussions that sometimes we still have in our network, but it's important to understand why people reflect like that and to get into that discussion, to deconstruct it and say, no, this is exactly the image that we need, and to be able to explain it and why that cell phone matters in that context. And it has nothing to do with what we are explaining around SRHR. Thank you. I'll stop here, but very fruitful. Thank you for your contributions.
Thank you. Thanks, Safid, and for reminding us that power is really a zero-sum game. Yep, to empower someone else means to give up power yourself. So it's important to remember that dynamic. And on that point, I think Agnes, UGHE, University Global Health Equity in Rwanda, does talk about empowering its own health professionals in a way that is appropriate and suitable to the needs of the African continent. What I'd like to ask is, what stops other universities in Africa from following the similar path that you've taken at UGHE? What are the internal, but also the external forces that prevents the adoption of what seems like, a sensible and obvious pathway to take for university development in Africa?
Education, like all sectors, need money. And money is controlled by the people who doesn't want to change because they benefit of the system they have created during decades, and they are resisting a lot. They have to give up a little, but they'll give really the minimum they can give. So to change that, we need to change the economic structure of the world. The majority come from the money, the economic power coming out of Africa is enormous, and Africa benefits nothing out of it. The Western world benefit about it. So if we understand that everything is based on the economical structure of the world that is there to maintain it, absolutely, we will not gain that battle. And we need to recover the power of our own economy and put it at service of our own people. And we need to educate the young people and people at university about that, and educate doctors and nurses to go in dialogue with leaders and make sure that the leaders in a district, when they go at national level, they contribute to spread those ideas.
Yeah. Okay. No, thanks, Agnes. And I'd maybe add to say that we also need health professionals that understand how the global political and economic structures and systems work. How is it that these structures and systems continue to extract resources from Africa? How is it that, the 0.1% of the world's population is able to command so much of the world's wealth? What are the systems and structures that enable this to happen? And how do we change that?
Yeah. And if we don't understand that, we are fighting the wrong fight and contribute to the maintain of the status quo.
Great. Thank you, Agnes. And thanks to all the panelists. We're going to have some open Q&A now. This is an opportunity now for members of the audience to put forward some questions. So if you do have a question, please click the raise hand button, turn your microphone and camera on, and address your question to the panel as a whole or to a specific panelist.
It seems we have some technical issues, so people could please type their questions in the chat box, aiming to everyone.
Okay, I've got a question now. One question is, again, coming back to the issue of terminology and the idea of decolonizing. The entire global development industry is based on this. We still have colonies. What do panelists think about using other terminology like power shifting, which is not perfect, but at least tries to capture what we can actually do? So this notion of maybe not always framing things in the language of coloniality or decolonization, but perhaps going straight to the core issue of power and thinking about shifting power so that power is distributed more equitably. Is there any value in talking more explicitly about power rather than using the terminology of decolonization? Anyone like to respond to that?
But your comment about the words is important, because we are spending so much time trying to define things that we don't act during that time. And the most important is to agree on the outcome we want, and the words can come after. And in any case, those words are in English, in French, they are not in an African country, language. So it's also a language of coloniality. So the most important is to agree on actions, what to do, and don't spend time about defining what we will do, because we are playing the game of the statu quo.
Yeah, okay. Thanks, Agnes. And certainly I think when we're talking about actions and behaviors, some of the other important words maybe to think about would be words like exploitation, words like misappropriation, words like extract, the extractive nature of colonialism, oppression, subjugation. So these are all active words that really speak to the issues that we're concerned about and the kinds of actions and behaviors that really we want to oppose and change. Decolonizing is perhaps a lot more abstract, and in some ways power shifting as well. It doesn't really speak to the core of the behaviors that are causing so much harm and inequity.
David, may I answer, just react to this question as well?
Yeah, do.
Allow me. So just from a Swiss perspective here now, so I'm just referring that it depends quite a lot on the context, how you work with which kind of work. So what works that as a word that you can provoke a political debate and aim for transformation. And here in Switzerland, where Switzerland always says we haven't been a colonial power, it's very important to talk about decolonialization, because we have been part of the colonial system. The culture here, our economics, and as well our sector of international cooperation was strongly shaped by colonial patterns and the colonial power, where we are part of it. So for us, it is still important that we here in Switzerland talk about decolonialization, because then we can tell the people that we, as Swiss society, are completely part of it.
Yeah. So you're making the point that in some particular contexts for particular issues, that terminology, that framing continues to be valid and important. But I guess the point is also that there may be other narratives, other framings that may be equally appropriate, and that could also be connected to the to the discourse around decolonizing global health.
please don't push the people to argue in English or in French about words. Push them to action, because this is also a game that it's playing globally. Let's come and discuss. And this is the role of the UN. The UN is called in French la belle inutile. Just because we go there, we talk, we don't take actions.
Thanks,
We
Agnes.
occupy the people to the wrong things.
David, if I could jump in a bit, sometimes words approximate intelligence, knowledge, capacity, and they are used to hide behind, the intelligentsia, those who are learned, particularly those who come from particular pockets of dominant knowledge, are using words to express their power, to express their depth of knowledge and understanding of context. I think what we need to do is to delink language from translating into knowledge. I hope you get the connection. If I speak to you from a particular language, my local language, or whatever language that I use, it does not have to imply that I am less because I can't communicate to you in the language which has been universalized. Two, we need to give space for multiple languages, because how do we move towards action? People need to understand what we are communicating, what it means to decolonize. So we must give expressions of decoloniality from our own context based on our own language and what it means. Working in informal settlements and interacting with people, and I'm asking, why is it that all products that you are using come from country X? What are you producing that is allowed to go to country X that you are benefiting by buying the things that you use? That is decoloniality, so that the common person can see, okay, when I'm consuming products made by a certain country X, it means I'm supporting their livelihoods. So the question is, how much is that country supporting my livelihood? Then they begin from there to say, okay, this is a relationship that is exploiting me because they are earning from me and I'm not getting anything from them. So that recognition has to be there. And then lastly, we must give room for multiple languages. And languages, I'm using it literally. It could be culture, it could be way of thinking, it could be identity, it could be indigenous knowledge, because language is a carrier of all that. So taking it away means we'll have relegated our culture, relegated our indigenous knowledge, relegated our identity, and relegated who we are. So I think language is still very important, but how it is used, because it is a tool, it carries power, it carries agency, and it carries actions sometimes. Thank you.
And David, if I can just briefly expand on Danny's points also with language. Yeah, the idea, shifting power is a key component to decolonization. But the reason we use the term decolonization is to provide the context, not just historical, but even present. If we're talking about decolonizing global health or shifting the power in global health, decolonizing global health itself, the term, is an evolution from its antecedents, international health. Before that, it was tropical health, and ultimately, in its original form, it was colonial health. So if we're really looking at global health right now, we have to acknowledge where did it come from as a concept. And as a concept, it came from coloniality. And it still retains not just, the language may have been softened in that evolution, but the structures underneath it have been reinforced over time. And we need to see what we can do to unpack that. I think that's very important. Last point I'll make is that in the Compile Initiative, there has been some work with Health Poverty Action and the Bond Network to explore alternative narratives, moving away from, in the case of development assistance for health or health aid, away from this charity approach and looking at how do we conceive this as a solidarity model. And I think language is a very important role in that.
Yeah. Great, thanks, Ravi. And maybe just I'd like to add that in my view, the Alma Ata Declaration of 1978 represents for me an anti-colonial expression of global health. You know, it's a quintessentially a anti-colonial declaration that speaks about a kind of global health that, you know, in 1978, WHO and others wanted to put forward, but sadly it didn't come to play. And we've instead had a different kind of global health emerge in the last 3 or 4 decades. But it's definitely a term. The term global health is a term that is contested. And if we go back to that Alma Ata Declaration, we see a form of global health that was anti-colonial. This goes back to 1978. So I want to get practical now. You know, Agnes talked about, you know, let's not just talk about all this stuff and discuss definitions. What are the actions? And here there's a question in the chat box about the pharmaceutical sector. What is the role of pharmaceutical companies in decolonizing global health? So there's a whole, I think, issue to unpack here about the role of pharmaceutical companies in acting as colonial agents themselves. And Ravi, you talked about the profiteering that occurred during COVID, and it's not just COVID, of course. There was a whole number of new billionaires that emerged out of the COVID pandemic. But we can also link the issue of the pharmaceutical sector to the intellectual property rights regime and think about also the colonization of knowledge and how that colonization of knowledge again produces a form of profiteering and exclusion to the benefits of medicine. So what in practical terms can a decolonizing global health narrative do with regards to the problems that we see in the pharmaceutical sector? What actions can we take? What can the decolonizing narrative bring to the table of the problem of inequitable access to medicines, vaccines, and diagnostics? Let me start with you, Agnes.
Do you hear me? Yes, I
Yes.
guess. I think if you want to sell drugs in my country, at least come and make them in Africa. So that so we have so many ways to do that. We need, first of all, to decolonize WIPO, I don't know, this World International Organization that is there for the statu quo. In one word, we need to shoot down the UN and start with rules that serve our continent. They are there for the statu quo. They are not there to help us to improve. They are there to help us to be in good shape enough to be exploited at the maximum. So you want to sell in Africa, show the profit you give to the continent. Come and do a factory in Africa to sell in Africa what is created in Africa. Help a university to create people skills in biochemistry, etc., etc. There is so many ways, and we have the power to do that.
Yes.
It's just that we don't do it.
Thanks, Agnes. Danny, you want to comment on this issue?
Yeah, I think I loved what the Nigerians did when they exposed France. They revealed that France was getting uranium from their country at probably 12 cents and earning about 300 or 200 euros per kilo of uranium extracted. This is the exposure we need to highlight that it's not charity. You're getting something. There are so many pharmaceutical companies making a kill from Africa, but they are hesitant to transfer their technology or build capacity. Let's expose them. For instance, in the non-communicable disease space, literally, we know there are not many. We know there are just about 2, 3, 4 companies that are making money out of it. Let's put the numbers to the table and tell them this is how much you are missing from Africa. Why is it so difficult for you to move technology proximity to where the people are? Then, of course, they have a lot of issues. You see, there is no capacity, there is no this, there is no this, and say, okay, these are the steps. We've created an environment, and I like what the Africa CDC is doing to discuss around how Africa can create an enabling environment to facilitate that technology transfer, building of capacity, preparing the ground. But still, there are some are hesitant, so we need to name them, not use the word shame them, but to highlight to them that they are already making money. It is in good common sense, in good practice, in practice of solidarity, that they see that the future and the present is in Africa, because we have the numbers and the game is with the numbers. So I think that is how the decolonial discourse can help shape the narrative and be run a bit faster than what we're doing now.
Agree with Danny, except that Danny, you give them the benefit of not knowing what they do. They know what they do.
Thanks, Agnes. Hafid, do you want to weigh in on this issue in 1 minute, if you can?
I'll try. I was born and raised in Algeria. This matters here because I can exactly understand where Agnes and Dani come from in their reflection, and I absolutely agree 100%. But I want to, my translator function as well is on what Martin was saying. I think we have to develop strategies depending on where we're standing. Again, so I cannot go simply to actions discussing here with the parliament or with the specific network. I need to make clear what we are talking about. So words and definitions matter in this context. If I want, political decisions, whether in Rwanda, whether in Algeria, whether in Switzerland, it's not just me saying it. I need to take people with me. And even if the actions, I agree with Agnes and Dani, but the actions are not clear since yesterday. They are clear for decades. And still many things did not happen. There are reasons to this. So we need to develop movement, like definitely agree with Agnes. We need to think in our positions, in our specific locality, what kind of strategies, next steps, actions are needed to not only develop movements, but get them into a momentum where we can actually create an avalanche, really to move things. And I think this is where we are. Whether, and this is where I started in the beginning, I'll stop on it, is in my position, in my organization, I can do so much. I'm trying. In my network, I can do so much. I'm trying. And if I can get it to a movement to really shape policies, national, transnational, international, absolutely. But we need to think from our position on what the possibilities are. And I'll stop here.
Great, thanks, Hafid. Ravi, you have 1 minute to weigh in on this topic. And I wouldn't mind it if you said something about, whether or not these pharmaceutical companies that are making vast profits are being adequately taxed.
I think there's been a lot of good work on the taxation. I'll highlight that the government of Colombia has been working to see if there can be an equitable tax regime across Latin America. And that's not specific to health, but I think it's good for public services in general. And so I think that's a good example of a Southern-led initiative, apart from what the OECD is doing to harmonize their own taxation models. But I think I have a bit more skepticism there. What I'll do is I'll add to what Agnes and Danny were talking about. It's beyond just technology transfer where global pharmaceutical firms might manufacture in southern countries. Much of the research that underlies manufacturing pharmaceutical technology has been based on public investments, and therefore it should be seen as a global public good. If we take that, we combine it with the TRIPS waiver, which is a way of waiving intellectual property because of urgent and public health demands and needs, then we do have the recipe for moving ahead. And I'm sorry I'm not answering the taxation issue, but this is a specific instance where there was no technical reason to deny the TRIPS waiver, especially 2.5 years ago when vaccines were becoming available in the emergency phase of COVID. It was very much of strong colonial powers dictating to the rest of the world what the consequences of that waiver would be, meaning economic retaliation. And I think we just have to lay that out.
Thanks, Ravi. Okay, well, that's been a fantastic Q&A. Thank you very much to all of the panelists. We've come to the end of that session, and it's for me now to hand over to Martin Lachon with closing remarks. Over to you, Martin. Thank you very much.
Yes, thank you, David, for your facilitation of this meeting. Thank you as well to the Global Health Center of the Graduate Institute for their work and organization of this meeting. I'm Martin Lachon. I'm the director of Medicus Mundi Switzerland, and I'm president of Medicus Mundi International. And as Medicus Mundi Switzerland, we are in the middle of a process of developing deeper knowledge, providing instruments and platforms for our 50 member organizations to confront themselves with the call to a decolonized modality of work. And one of the milestones in our process is a report elaborated by Labila Sumaya Musoke, part of the Kampala Initiative, and Thomas Schwarz, Medicus Mundi International, with the title Swiss NGOs Engaged in International Health Cooperation, How to Respond to the Call for Decolonization. And this report will be finalized very, very soon, but so I can give you some first insights, which are reflecting as well quite nicely what we have discussed today. So it sums it up a little bit. So there are already some organizations on the wave of transforming, and we had good examples to learn from today. That was Terre des Hommes Switzerland, represented by Hafid. This is such a case. But anyhow, NGOs need to reflect on their work and honestly take up the critique of aid. Our sector has to overcome racism and stereotypes. And there is a way to go from equal partnerships to jointly promoting change by participatory approaches. And more than that, how can organizations, that what we have discussed today as well, shift power? And as well, critically assess the notion of localization, as Ravi has already at the beginning mentioned. So there are organizations adapting their programs, but the way forward to a decolonized international health cooperation is there where it will be probably more hurtful in the strategies and in the structures of the organizations. So beside these internal dimensions of organizations, there are as well factors outside of the organizational level that cannot be ignored and have been discussed today. There are the structural issues on the donor side, colonial patterns entrenched by back donors within the development sector through imposed terms and modalities. And we should not ignore that international politics and economic systems, global health, we talked about care train as one example today, as well as in the leading knowledge systems are shaped by colonial roots and patterns. This means change begins in our organizations, but cannot end there. We should raise the flag for justice, equity, solidarity everywhere in every sectors. This emancipatory approach and perspectives seem to me very important, especially in this world out of order. And we should always be cautious when authoritarian governments accuse and blaming the colonial West while acting, and this is again referring a little bit to the introduction of Ravi, when they acting in the same old colonial patterns, with exclusion of a huge part of the population, with the militarization of their societies, with the exploitation of humans and the nature, with open and hidden violences on all the levels. So thank you everyone for being here with us. And I think I hand over to Ellen, our host.
Thank you, Martin. Thank you, everybody, for joining today's event. This has been an amazing engagement in the chat box. It's been super active, a really dynamic Q&A. Thank you to the audience for engaging. We'd appreciate it if you take a couple of minutes to answer just a couple brief questions that will come on automatically at the end of this event. The recording of the event will be available in a couple of days on our events page, ghplatform.org. And please also subscribe to our newsletter so you are informed of all of our events. And we hope to see you at our next Global Health event, which will be on November 27th. And it's called Dying for Life, Are Mothers Still a Global Health Priority? Another very provocative event on a very important practical issue. So thank you all and hope to see you on November 27th. Bye.